Hello everybody, welcome to Number 1 Doctor channel. Today video is about which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like, share our videos, subscribe to our YouTube channel Number 1 Doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about the gallbladder. Gallstones are responsible for the vast majority of biliary tract pathology. There is a spectrum of biliary disease caused by gallstones, as noted below. Although the obese woman in her 40s is the textbook victim, incidence increases with age so that eventually they are common in every body, particularly Mexican Americans and Native Americans. Asymptomatic gallstones are left alone. Biliary colic occurs when the stone temporarily occludes the cystic duct. There is colicky pain in the right upper quadrant, radiating to the right shoulder and belt-like to the back, often triggered by ingestion of fatty food, accompanied by nausea and vomiting but without signs of peritoneal irritation or systemic signs of inflammatory process. The episode is self-limited 10, 20, maybe 30 minutes, or easily aborted by anticholinergics. If sonogram establishes diagnosis of gallstones, elective cholecystectomy is indicated. Acute cholecystitis starts as a biliary colic, but the stone remains at the cystic duct until an inflammatory process develops in the obstructed gallbladder. Pain becomes constant, there is modest fever and leukocytosis, and there are physical findings of peritoneal irritation in the right upper quadrant. Liver function tests are minimally affected. Sonogram is diagnostic in most cases: gallstones, thick-walled gallbladder, and pericholecystic fluid. Rarely, a radionuclide scan might be needed, would show uptake in the liver, common duct, and duodenum, but not in the occluded gallbladder. NG suction, NPO, for fluids, and antibiotics cool down most cases, allowing elective cholecystectomy to follow. Physicians typically endeavor to do it in the same hospital admission, as an urgent case, though it is not a middle-of-the-night true emergency. If the patient does not respond, men and diabetics often do not, emergency cholecystectomy is needed. Emergency percutaneous transhepatic cholecystostomy may be the best temporizing option in the very sick with prohibitive surgical risk. Acute ascending cholangitis is a far more deadly disease, in which stones have reached the common duct, producing partial obstruction and ascending infection. Patients are often older and much sicker. Temperature spikes to 104-105 F, with chills, and very high white blood cell WBC count indicate sepsis. There is some hyperbilirubinemia, but the key finding is extremely high levels of alkaline phosphatase. For antibiotics and emergency decompression off common duct, ideally by ERCP, alternatively percutaneous through the liver by percutaneous transhepatic cholangiogram PTC, or rarely by surgery, are life-saving. Eventually cholecystectomy has to follow. Obstructive jaundice without ascending cholangitis can occur when stones produce complete biliary obstruction, rather than partial obstruction. Presentation and management were detailed in the jaundice section. Surgical injuries to the biliary tract are devastating complications, with lifelong adverse consequences due to the tendency of those structures to stricture as they heal. Biliary pancreatitis is seen when stones become impacted distally in the ampulla, temporarily obstructing both pancreatic and biliary ducts. The stones often pass spontaneously, producing a mild and transitory episode of cholangitis along with the classic manifestations of pancreatitis: elevated amylase or lipase. Sonogram confirms gallstones in the gallbladder. Conservative treatment: NPO, NG suction, for fluids usually leads to improvement, allowing elective cholecystectomy to be done later. If not, ERCP and sphincterotomy may be required to dislodge the impacted stone. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef Ahmed.